Once again, this is Lisa Klein, and I'll be going over ischemic strokes with this lecture. So the objectives of this lecture, at the end, you'll be able to list at least 3 causes of an ischemic stroke, define what the ischemic penumbra is, and list at least 5 stroke risk factors. There are 2 types of stroke. The first type that we're going to be talking about in this lecture is an ischemic stroke. And this comprises when we talk about ischemic stroke and transient ischemic attacks. The second type is hemorrhagic stroke, and that encompasses the non-traumatic intracerebral, intraventricular hemorrhages, including those caused by aneurysms, arteriovenous malformations, intracranial venous thrombosis, and other vascular issues. But we're going to be focusing on ischemic strokes here. So when we look at the pathogenesis of ischemic stroke, this accounts for nearly 85% of all strokes. Of the 85%, 20% of them are caused by atherosclerosis, so plaque buildup in your arteries. 20% of the ischemic strokes are caused by embolism, most usually from the heart as a cardiac embolism due to atrial fibrillation. 25% of strokes are lacunar strokes, and these are small vessel strokes usually caused by high blood pressure or uncontrolled high blood pressure. And then about 30% of strokes are what we used to call cryptogenic strokes, but now are called embolic strokes of undetermined source, or ESUS for short. And these are strokes that, following the workup for a stroke, we don't know what actually caused the stroke, but we believe it has some embolic source that we just can't identify from where. These ischemic strokes are part of a vascular disease, and it's part of what we consider the process that's similar to acute coronary syndrome for those patients with unstable angina and MI, as their cholesterol and plaque are building up over time and breaking off. It's much similar to how a patient is suffering a heart attack from having a clot go into their heart, but instead the clot goes to their brain. Thus, it's an ischemic stroke, or what we can call a brain attack. So ischemic strokes, accounting for 80 to 85% of strokes, are obstructions of blood flow to the brain that lead to ischemia, which is lack of oxygen, and a ventral infarct, which is tissue death. This involves both ischemic and transient ischemic attacks. And we can see here in the picture how the blocked flow, very much like if you have piping in your house and you have blockage, doesn't get through, and thus both blood and oxygen doesn't get to all your brain cells. For transient ischemic attacks, these are also known as mini strokes, and these are warning signs that a stroke is going to happen. A transient ischemic attack is a transient episode of neurological dysfunction that is caused by focal brain, spinal cord, or retinal ischemia without acute infarction. And of patients presenting with an ischemic stroke, 7 to 40% of them had a TIA before their stroke. So the patient pretty much, they look like they've had the symptoms of a stroke, but because the symptoms resolve, they don't seek medical attention. They're like, I'm going to continue with my day. Or their symptoms come and they're like, I'm going to sleep on it, and maybe they'll resolve. And of course, these are warning signs that you're going to have a stroke. And a patient and a person who has had 1 or more TIAs is actually 10 times more likely to have a stroke. Also, about 1/3 of the people who have a TIA go on to have a more severe stroke within a year. For TIAs, about 41% of them last less than an hour. But interestingly, if you actually get an MRI and look at the diffusion-weighted image of these patients, in about 30% of those, their MRI will be positive for actually having a stroke. And if the patient's symptoms last up to 12 hours, 50% of those patients that have TIAs will also have a positive MRI for a stroke. So strokes will occur within 90 days in about 10 to 20% of TIA patients. And approximately 50% will occur within 24 to 48 hours of a TIA. So TIAs are not something we should take lightly. It is something we try to educate not only our patients, but their family members that you have any of the symptoms of a stroke, even if they don't go away, you need to seek medical attention as soon as possible. When patients arrive to the emergency department, one scale that we can use is called the ABCD2 Score. And this is looking for patients that arrive with a probable TIA and their likelihood of having a stroke within the next few days. So they look at certain risk factors, including age, blood pressure, the clinical features of the TIA, the duration of the TIA, and whether the patient has diabetes. And then you can see on the chart to the right, the higher your score is, the greater likelihood that you're going to have a stroke within the next few days. And so that can help decide whether a patient can get some of the stroke workup as an outpatient, or if they should be admitted to the hospital because the risk is much higher of having an imminent stroke. As far as risk factors for ischemic stroke, we have some that are within your control and we have others that are outside of your control. For those within your control, hypertension is the leading cause of ischemic stroke. Other things within your control would include smoking, diabetes or having poorly controlled diabetes, a poor diet, physical inactivity, obesity, high cholesterol or carotid artery disease, having atrial fibrillation, and other heart disease or sickle cell anemia. What is outside of your control is your age, and we know that your chance of having a stroke approximately doubles for every decade of life after the age of 55. We know that while stroke is common among the elderly, we do have a lot of people under the age of 65 that also have strokes. Family history, so if you've had a first-degree relative that has had a stroke before the age of 65, or even a heart attack before the age of 55, that puts you at greater risk of having a stroke. Your race and your gender also put increased risk. Women have more strokes than men, and strokes kill more women than men. The use of birth control pills, pregnancy, history of preeclampsia or eclampsia, or gestational diabetes, along with smoking, postmenopausal hormone therapy, may pose an especial stroke risk for women. As well, if you've had a prior stroke, TIA, or heart attack. Looking at the risk factors here in the UAE, we can see that physical activity, both for men and women, and this is data from 2016, we have very high rates, with nearly 38% of the population being physically inactive. We can see here another one that has highest rates would be tobacco use. We can see that is much more used by men, with 38% of men compared to 1% of women. And then down here at the bottom with obesity, it probably correlates as well with physical inactivity, is that we have about a third of the population, once again, that is considered obese. Now, when a patient has had a stroke, there's an area called the ischemic penumbra. And where the stroke is, that's where you have the dead tissue. That is the core of the infarction. And the ischemic penumbra is the area around that core infarct with minimally surviving cells. And this is our target for medical and pharmacological interventions and to reestablish adequate perfusion. So you can see in the picture here that we have the dead tissue in black, but the penumbra that's around it in orange, that's a much bigger size. So when we have a patient that's had a stroke, we'd much rather keep the stroke, that minimal small size of the stroke that's already happened with the dead tissue, instead of it expanding to this penumbra. We know that within an hour of a hypoxic ischemic event, the core of infarction already starts dying, and then those minimally surviving cells, this ischemic penumbra, these cells are at greatest risk for neuronal death, but they are alive and they are salvageable. And so we really are going to focus our care to save this area. And so patients, because it has decreased perfusion, frequently we do permissive hypertension to keep blood flow to this area. But this tissue is also friable. It's not extremely happy. So we want to make sure we're not having too high of blood sugars or too low of blood sugars, because we want to keep this tissue alive as well. When we look at our patient's scans, a diffusion-weighted MRI, and if we look at the diffusion versus perfusion images, if we see a mismatch, then we can see here on the left in the white, we have a core infarction area. But if you look on the left, that red area, that's the whole area that's at risk for also dying and becoming infarcted. So that's the area we want to allow our patients to salvage, so that their stroke deficits won't be won't be worse. So we have some treatment options for patients that have had an ischemic stroke. So for acute revascularization, so opening up of the vessels, we have intravenous thrombolytic therapy. Our go-to one is alteplase. We also call it TPA, and we can give it within 3 to 4.5 hours of stroke onset. That's not a lot of time. As well, options we have include endovascular recanalization with a mechanical thrombectomy. So you can see here in the picture at the bottom right where we have stent retrievers that go in to actually pull out the clot. This we try to do within 6 to up to 24 hours since the patient was last known well. And then we might also do a combined intravenous or intraarterial therapy, and this might be also followed by mechanical thrombectomy. If we give intraarterial TPA, it usually is within 3 to 6 hours of onset, frequently followed by a mechanical thrombectomy. And then the other part of, ischemic stroke management is actual medical management. Because if a patient doesn't come within the early time frame, it means they're out of the window to get any of these therapies. So it means we're going to medically manage them. Time is brain. As I said, a lot of these things have to be given within 3 to 4.5 or even up to 24 hours. But when we look at the data of how fast patients arrive to the hospital, only about 36% arrive within 6 hours, and only really 27% coming within 0 to 3 hours, meaning that of the 64% of patients that come to the hospital with a stroke, they can't get TPA because they're outside the window. Up next, we're going to go over hemorrhagic strokes.